funded and run by the government.
Honourable Minister.
Thank you, Mr. Chairman. Thank you for that question. The Human Organ and Tissue Transplant Agency, if you would recall, about 3 years ago, we came here and we passed legislation dealing with transplant because we were doing transplants, but we didn't have legislation to govern it. So with transplant, you need to have very strict regulations. You have to get a body that can license the hospitals to be able to do transplant, to go in and make sure that they're following all the rules. You have to make sure that when somebody is getting a donation, let's say of a kidney, that they haven't been coerced to donate their kidney. So there are lots of things that you need to put in place. So the job of this agency is to make sure that we have all those the regulations in place, be able to certify hospitals who want to do transplants, and also to make sure that we have properly trained people to be able to deliver these services. The only hospital that is licensed to do transplant in Guyana is the Georgetown Public Hospital, because they have met all the requirements under the agency. Right now, we're doing 2 major types of transplants. We're doing kidney and we're doing corneas. And we have a partnership with Donation Transplant Institute in Barcelona. And again, you would see in another month that we'll be signing an agreement with the EU and DTI to be able to help to improve the capacity of our doctors to do transplant in Guyana. Another thing that you should know is that all the transplant programs in the Caribbean, when they want to do a match between a donor and a recipient, we have to send that match to Miami to be able to get that test done. Last year, we were able to procure the equipment, and we have someone right now in India that is completing training, and when she returns in about 3 months, Guyana would be the first country in the region who would now be able to do HLA testing. So this would help us to advance our transplant program.
Honourable members, I now put a question that is sum stated for Agency 47. Program 471, current expenditure stands part of the estimates. Those in favor say aye. Those against say no. Ayes have it. The sum stated now stands part of the estimates. Let us turn to page 538. And I propose the question that the sum stated for Agency 471, capital expenditure, stands part of the estimates. Honourable members, I now put a question that the sum stated for Program 471, capital expenditure, stands part of the estimates. Those in favor say aye. Those against say no. The ayes have it. The sum stated now stands part of the estimates. Honourable members, let us go to pages 260 and 261. And I propose the question that the sum stated for Program 472 on the Agency 47, Ministry of Health, 472, current expenditure, stands part of the estimates. The Honourable Member, Dr. Campbell.
Thank you, Mr. Chair. Honourable Minister, at line item 6116, contracted employees, there's an increase of $4 billion. Can you give us a brief breakdown of what's driving that increase? Brief.
Honourable Minister.
Oh my gosh. No, I'm so anxious to get to regional and clinical services. Sorry.
So, Honourable Member, I can put.
Just a quick, sorry.
Honourable Member, Ms. Hallett.
Thank you, Mr. Chair. 6281, Security Services. Mr. Chair, when you look from actual 2024 to now, we see a large number is there, but then when you budgeted in 2025, you have 36 million, revised 36 million, but now it's at 85 million. Can the Honourable Minister state what this increase is for? Which building is being secured under this line item? And the service provider?
Honourable Minister.
Thank you, Mr. Chair. Thank you, Honorable Member. We have a number of locations that we're securing. We're spending approximately $48 million at the Infectious Disease Hospital at Lilindale. We are spending $13.5 million for the National Public Health Reference Lab, $12.3 for the NAPS location, and we have another $11.3 million for vector control services.
Thank you, Minister.
Mr. Chair, just a quick follow-up. The security that is being provided, is this, how many persons are stationed at these different places that requires that amount?
Honourable Minister.
So when you look at the different locations, we have approximately 28 persons on a shift basis. So 3 shifts, 28 people.
Thank you, Mr. Chair.
Honourable Member, Dr. Richards.
Thank you, Mr. Chair. What I have is not really a question, but more of seeking a little bit of clarification. I'd like to turn attention to Volume 2, page 222. On the disease control, communicable diseases, at 47208, I noticed there's a sub-program here for chronic diseases. And also at 478, disease control, non-communicable diseases, there's also a sub-program there for chronic diseases. So I just would like the Minister to say the rationale with this entry here.
Honourable Minister.
Thank you very much, Mr. Chair. Thank you very much, Honourable Member. The second program that we have in the ministry is communicable diseases. And the 8th program is non-communicable diseases. So communicable diseases would be the infectious diseases,
yes,
things like HIV, TB, and so forth. And the non-communicable diseases would be your hypertension, diabetes, cardiovascular disease, respiratory disease, and so forth. Does that clarify your?
Okay, thank you, Honourable Minister. Just a follow-up.
Sure.
Go ahead.
Now, my concern was that under communicable diseases, there's a sub-program for chronic diseases, right? So I was just wanted to know why that is, when chronic diseases should be under non-communicable diseases.
Honourable Minister, is it merely an opinion, or there are sound, rational, scientific reasons for placing these where they are?
Thank you, Mr. Chairman. Thank you, Honourable Member. If we look at page 220, right, that's where we're looking at?
It's 222.
222, right?
Mm-hmm.
Hold on. Which one of the things you're looking at here?
Disease control, communicable diseases. You have various sub-programs under that.
Right.
The last one, 47208.
Yeah. Okay.
Right?
Uh-huh.
So I was just wondering why that
Right.
exists there under infectious diseases, communicable diseases.
Thank you, Mr. Chairman. I now see so before we had this EIT program, which is a recent thing, probably about 4 years ago that we have set up this EIT program that deals specifically with chronic non-communicable diseases. So there used to be on the disease one broad heading. So this probably might be a remnant of that. But in any event, this heading 472, disease control, communicable diseases, talks more to infectious diseases, right? And as you know, there can also be some infectious diseases that would have a chronic thing. When we look at acute and chronic, it's basically the time frame, right?
Yes,
so,
yes.
So it doesn't, you know.
Mr. Chair, thank you, Honorable Minister, for your explanation.
Thank you very much, Minister and Dr. Richards. The Honorable Member, Ms. Natasha Singh.
Thank you, Grandma Chair. Grandma Chair, I'm looking at page 229, volume 2. The first indicator speaks to incidence of HIV per 100,000 in our population. And there is a slight reduction in the target. My question is, could the Honorable Minister say to us, what are the interventions in relation to the reduction of incidence here?
Thank you very much,
Minister.
Mr. Chairman. Thank you very much for that question. So HIV incidence is the amount of new cases that you get per year, right? And what we have been doing is working to make sure we reduce people getting infected. We have a number of preventative programs. So one, we have a program where first of all, we do a lot of education in terms of HIV. We have also been giving to persons who feel that they are at risk for HIV, we can give them pre-exposure prophylaxis. That is antiretroviral medicine that can prevent you from becoming infected. So that's a program that we have implemented, and that's working for people who deem themselves to be at risk. We also have been giving things like condoms to persons who want them, and on an annual basis, we distribute close to 5 million pieces of condoms across the country. We have different types. So there are a number of preventative measures that we take, and I think this has certainly led to the reduction. Now, apart from that, there's another thing in HIV, the trajectory of the disease. So if you manage people who already are infected with HIV and you get them to be virally suppressed, it means that they cannot transmit to somebody else. So what we've been doing is working to ensure that most of our patients are virally suppressed. We manage now close to about 7,800 patients who are on ARVs, and of those, most of them are virally suppressed. And when we come to the labs, you would see that we have bought a piece of equipment there where we can do viral loads. So we are monitoring our patients using viral loads. So once they are virally suppressed, they cannot transmit. And that has also contributed to the reduction in cases. That does not mean that we don't have to be vigilant. So we have been setting up clinics, going out, raising awareness. And while we are doing it for HIV, there are also a number of STIs that we look for: syphilis, gonorrhea, chlamydia, and a whole host of other things. And we are using the HIV program as the entry point to get to the other STIs.
Comment Chair, a follow-up?
Go ahead, Honorable Member.
So, Minister, I am aware a lot of what you said the public relations in Region 4 in particular is commendable. That same context, can we say what is happening, for instance, in the hinterland regions like Region 9, Region 8, what in Region 1? We've had a lot of stories in Port Kaituma particularly. Is it the same level of awareness? Is it the same level of treatment in those regions?
Thank you very much, Mr. Chairman. Thank you very much, Honorable Member. It is the same, because what we have done, we have trained a lot of the primary healthcare physicians to be able to manage HIV. So regardless of what part of the system you're located, you can be able to treat HIV. So it's no longer that vertical program. Now, with people who have HIV for many years, and if they're probably not taking their meds and so forth, some of them can develop certain complications. Those persons with complications would need more of an expert to guide them through their treatment and maybe even to change their treatment. So when our primary care physicians, if they see people like that, then they'll refer them to the specialists who would be able to change their meds and manage some of the complications that they have. But most of our patients now, you know, before HIV was like a death sentence. So when people get it, after a couple of years, you see they progress to AIDS and they die. Now we don't see that. Most of our patients are living, and most of them probably died from something else, heart disease or some other thing. So they do very well on the ARVs, and that, I think that in itself has been a success story for the HIV program.
Thank you, Minister. Honorable members, I now put the question that the sum stated for program 472, current expenditure, stands part of the estimates. Those in favor say aye. Those against say no. Ayes have it. The sum stated now stands part of the estimates. Program 538, sorry, page 538, program 472, capital. And I propose the question that the sum stated herein stands part of the estimates. Honorable members, I now put the question that the sum stated for this head 472, capital expenditure, stands part of the estimates. Those in favor say aye. Those against say no. The ayes have it. The sum stated now stands part of the estimates. Pages 262 and 263. I propose the question that the sum stated for program 473, current expenditure, stands part of the estimates. Honorable members, I now put the question. Honorable member, Ms. Halley.
Thank you, Mr. Chair. Mr. Chair, I'd like to look first at the line item 6116. Can the Honorable Minister state what are the designations of the newly employed persons under this line item?
Minister.
Thank you very much, Mr. Chair. Thank you very much, Honorable Member. We have here 11 new persons. The first one would be a senior dental surgeon. We have 6 other dental surgeons, 1 public health nurse, 1 environmental health officer, and 2 dentists.
Thank you, Minister.
Thank you, Mr. Chair. Honorable Minister, if I may, the current salary, not salary, staffing is a 227. Can you say what the vacancy is for this particular heading?
Honorable Minister.
Go back over your question. please?
The vacancies, sir. You have 227 staff. I'm trying to figure out if that's you're fully staffed or you have vacancies and what that number is.
Honorable Minister.
You're referring to what? Temporary?
6111 to 6117, sir.
So what is it that you're trying to get at? I'm just trying to understand your
I'm
question.
trying to figure out if you're fully staffed now or whether you still need more persons to fill any vacancies that may exist under this line, under this program.
Honorable Minister.
So for this program, right now the people who we have on staff, we are providing an allocation to pay their salaries. If during the year we employ additional people, then we'll go to the Ministry of Finance and we'll talk to the Ministry of Finance about those vacancies.
Thank you, sir.
Is that what you're looking?
No, it's not, but I think
Okay,
you know
all
what
right.
I was asking.
Thank you, Minister. Honorable members, I now put the question that the sum stated for Program 473, current expenditure, stands part of the estimates. Those in favor say aye. Those against say no. Ayes have it. The sum stated now stands part of the estimate. Turn to page 538, honorable members, and I propose the question that the sum stated for Program 473, capital expenditure, stands part of the estimates. Honorable members, I now put the question that the sum stated for Program 473, capital, stands part of the estimates. Those in favor say aye. Those against say no. Ayes have it. The sum stated now stands part of the estimates. Please let us turn to pages 264 and 265. Sorry, we now at, yes, 264, 265. Regional and clinical services. And I propose the question that the sum stated for Program 474, current expenditure, stands part of the estimates. The honorable member, Mr. Campbell.
Thank you, Mr. Chair. And through you, Mr. Chair, I'm repeating the question that I rushed to earlier. There's been an increase from 6.2 billion to 10.1 billion under line item 6116. Can the Honorable Minister give us a short breakdown, just by categories? I don't need the actual numbers of the employees that are driving that increase.
Honorable Minister.
Thank you very much, Mr. Chair. Under this line item, Mr. Chair, over the last, and the member would have checked this already, you would have seen that there's an increase of 1,091 new employees. And among those persons that we have employed, we have 869 nursing assistants. We have employed 377 medical officers. We have 97 medical registrars. We have 299 staff nurse. I'm just calling the big categories, right?
Go ahead.
So those are some of the bigger categories, but I can go through, and we have 77 patient care assistants. But we can go through the details if you like.
Mr. Chair, with your permission, a follow-up, please.
Go ahead.
Honorable Minister, and just to confirm that these contracted employees are for the regional hospitals. Now, and forgive me, I'm no medical doctor, but I just wanted a rough idea from you. I have a listing of the departments that should fall under regional hospital. The operating theater, ICU, high dependency unit, the NICU, neonatal intensive care, delivery suites, 24/7, especially 24/7 emergency room is a commitment that's in your policy, inpatient, outpatient, and so on. Can you roughly as a guide, share with me. I know time is against us. We only got 2 hours we could spend until tomorrow morning. Roughly the number of nurses, doctors, and registrars that are needed to staff any of these regional hospitals.
Minister?
Yeah. Thank you, Mr. Chairman. Thank you, Honorable Member. What we did, for each of the new hospitals that we have opened, that's Lima, Dikendren, Diamond, Enmore, Bath, 75. What we did, we worked out the departments that we have there, so accident and emergency, surgery, internal medicine, obstetrics and gynecology, anesthesia. I think those are the main ones. And we also have a dental department. We have a 24-hour lab. We have imaging. We have 24-hour pharmacy. So for those, we have adequate staff. So each of the areas we have, for the head of department, we have either a consultant or a senior registrar for all of them. And under them, they have a number of GMOs that are working. So that's with your doctors. Then for the nursing, we have a matron for the hospital, and we have a number of the staff nurse. We have registered nurses. Then we have registered nurses midwife, so that they can function in the obstetric suite. And in addition to that, then we have patient care assistants, we have nursing assistants, and we have some, I think those would be the categories there. But for all of them, we have adequate staff at each hospital, and we are able to run a 24-hour shift for every one of the hospitals. We also have, I missed when I spoke earlier, pediatrics. So we have a pediatrician at every one of the hospitals.
Thank you very much, Minister.
Follow up, sir. Would the Honorable Minister, would it be possible for you to give me numbers just for my own personal records? Like, so for each, you said consultants, GMOs, matron, staff nurse, registered nurse, midwives, just those categories. Numbers for each one of these, rough numbers per regional hospital.
Minister?
Thank you, Mr. Chair. Those numbers are available. I don't have them here, but when I answer a question from Honorable Member Flubes, when she asked about Diamond Hospital, I actually gave her a breakdown of each of those categories. It's basically the same thing for all the other hospitals, but I can make that available. I don't have it with me here now.
Thank you, Minister. Honorable Member, Ms. Finance.
Thank you, Mr. Chair. Follow up on the same line item. Firstly, could the Honorable Minister, through you, sir, say what is the remuneration for both the patient care workers and the nursing assistants?
Honorable Minister.
A patient care assistant would receive approximately 145,800.
And the nursing assistant?
Huh? No. No, I think the patient care would be a little bit lower. The patient care would be around 105,000, and the nursing assistant would be about 120 and a little bit more.
Thank you. A follow-up through you, sir. Could the honorable minister confirm that he's saying there's a pediatrician at all regional hospitals, whether or not that is the case for Region 7, the Bartica Hospital there, the regional hospital?
Thank you very much, Mr. Chair. The hospitals I was referring to was the 6 new hospitals that we have in answering the honorable member. At Bartica, we do not have a pediatrician there right now. Dr. Singh, who is at West Demerara, would normally cover, would go in once a week to offer some coverage. But the general medical practitioner that we have there would be able to do a lot of the pediatrics, because that's part of what a general practitioner does.
Could the honorable minister further say if there's a general surgeon at the Bartica Hospital?
Honorable Minister.
We have a surgeon that is at the Bartica Hospital. The types of surgery that she does, I can't give you right now, but we have a surgeon that is located there. In addition to that, we have the obstetrics and gynecology. I think you know the two people well who are there at the Bartica Hospital, obstetrics and gynecology.
Oh, I know that. Yeah.
Right.
Well.
Thank you, Minister.
And finally, if through you, sir, with your permission, same line item.
Go ahead.
Thank you. Could the honorable minister confirm whether or not the recently hired hospital administrator and operations manager is catered for on this line item, and if so, what are their remunerations?
Honorable Minister.
I'm told that for the operations manager, that the salary is $430,000 per month, and for the administrator, it's $525,000 per month.
Thank you, Minister. Honorable members, let me just give you the lineup of the honorable members who have questions to ask. I will recognize Dr. Richards, Professor Hines, MP Femi Corlett, and MP Ganesh Mahipal, then back to Dr. Campbell. Dr. Richards.
Thank you, Mr. Chair. I just a follow-up on in regards to staffing at the 6 regional hospitals that were built. Although we understand the importance of quality healthcare for our population, I just want to follow up by asking the Honorable Minister, is there any shortfall when it comes to specialists, not just the pediatricians, but the other specialists as it relates to all the other 6 hospitals?
Mr. Chair, thank you for that question. So the area of specialty that we want to provide services would be at accident and emergency for trauma, obstetrics and gynecology, surgery, internal medicine, pediatrics, and we also have anesthesia. So those are the basic services that we're providing. In addition to that, we have the dentistry. So we have a suite there for 2 dentists. We have a suite for an ENT specialist, who in many of the places we have a technician that is there, but we also can have a visiting ENT person going there to look at specialized cases. We also have provision there for speech therapists, and we have special facilities in each of these hospitals to do that. Audiology, but many of these can be visiting people who would come in and hold specialist clinics. We have already started to also send the nephrologists to go and visit the different hospitals and have specialized clinics. We have the cardiologists that would be doing specialized clinics. So you have, not everybody is located there, but they go out to do specialized clinics. And one of the other things that we're doing, and starting from this year, you know, at Georgetown Hospital, they have a set of medication that they would offer, but when patients are discharged from the hospital, they can't get them in their region. So we are now making the formulary one where it would be accessible at these regional hospitals, because you have more professional or more specialists at these hospitals that are able to offer care. So you don't have to come back to Georgetown to get your meds there anymore. You'll be able to get it at the regional hospital. So there are some changes that are happening in the system, and in some cases, some of this, we are right now transitioning to this new system, but that's the direction in which we're going. Okay?
All right, thank you, Honorable Minister. Just one follow-up, Mr. Chair, if you would have me. So we understand, based on the explanation given by the Honorable Member, that the specialists are generally is there a plan in the future for us to have these specialists permanently stationed at the various regional hospitals?
Go back that question again. Sorry.
Plan in the future for us to have these specialists permanently stationed at every regional hospital, rather than having them visit every, monthly or weekly or?
So, thank you, Mr. Chair. Thank you, Honorable. So the core specialities are all there permanently.
Okay.
They don't shift. They're there. So they can offer services. And then we have the people who are probably, you might call them super specialists, who would come in and offer these specialized clinics, like in cardiology or oncology and so forth. It is hard to locate because we have very few of those persons, so it's hard right now to have them at every hospital permanently placed. But in the future, as we recruit more people, that might become a possibility. And just maybe to give you a sense of maybe how these hospitals, the 6 hospitals, are functioning. Up to the end of last year, since we opened and up to the end of last year, we have seen, so for BAT, for example, we have seen 5,177 patients in the various departments. At Lima, we have seen 4,446. At Dikendren, 5,315. At number 75, 6,196. At Enmore, 6,200. At Diamond, 8,689. So a total of 36,000 persons would have gone to these different specialized clinics. We also have been doing a lot more laboratory tests and interventions. So At Bath, we did about 41,789 laboratory tests. At Lima, 58,985 laboratory tests. Dekendron, 16,571. Number 75, 91,500. Enmore, 19,106. Diamond, 107,092 tests. So a total of 335,000 laboratory tests that were done. X-rays for all of the hospitals, these 6 hospitals, 34,188. CTs, 3,905. Ultrasound, 14,544 ultrasound. Each one of these hospitals, we have a blood bank there, and we were able to collect 826 units. The dental procedures that we have done at the hospitals so far would have been close to 9,122. Hearing aids that we were able to dispense at these hospitals, we would have seen and given out 157 hearing aid at these hospitals. We did 6,129 ECGs. So you get a picture of some of the things that the hospitals have done since we have opened.
All right, thank you, Honorable Member. I have one final question, Mr. Chair, if you have me, one final question. This is a question about the Kokwani Hospital. In the foreseeable future, is there a possibility that we will have an ultrasound personnel there and a GMO for the Kokwani Hospital? Because currently, right now, there's only one GMO doctor stationed at that hospital facility.
Yeah. Thank you very much, Honorable Member. As you know, we have been upgrading Kokwani, right? Yeah. So we have added a new accident and emergency. We have added a new operating theater. Well, it's the first time I think they're having an operating theater. We have put in a space there for a digital X-ray, and there are a number of other improvements that we have done at the Kokwani Hospital. As we are building out new services, we have to add more people. The ultrasonographer that we had at Kokwani, that person had to go back, but we are now working on getting a new person to come and to take on that responsibility. But again, they are what we want to do for this thing to become more sustainable. We have now an ultrasound course that the ministry in collaboration with Mohawk College in Canada is running. So we want to identify people from the community that we can train. So if there are people like in Kokwani or wherever we have these ultrasound machines, we are willing to put them through a training program, and then once they complete successfully their training, we'll recruit them and they'll have a job with us at the hospital in their community.
All right, thank you, Honorable Member.
The Honorable Member, Professor Hines.
Thank you very much. All right. Thank you very much, Mr. Chairman. Honorable Minister, can you say whether this category Yes. Can you say whether this category of contract workers include the foreign or imported healthcare workers?
Honorable Minister.
Thank you very much, Mr. Chair. Thank you very much, Honorable Member, for your question. No, they're not under this line item.
Thank you, Minister. Honorable Member, Ms. Amy Corlett.
Thank you, Mr. Chair. Line item 6271, telephone and internet charges. So I've noticed that 40 million was budgeted last year, and 39,511,000 was spent. However, I noticed that 177 million.
You'll get a chance to re-ask. Just ask the persons who put their light on and take it, please take it off because I would record your light coming on and off. If you leave it on, we will get that interruption. Go ahead, Honorable Member.
Yes, so I've noticed that 177,964,000 was budgeted for this year. So I want to know what is the reason for such a large increase since we only spent 39,511,000.
Thank you very much, Mr. Chair and Honorable Member. Thank you for that question. So under this heading, and the reason for the increase is that we have run some specialized lines to each of these hospitals. So the 6 new hospitals that we have in place, they have dedicated lines to them. And the reason why we did that is because we want to transmit the images that we generate there. So let's say we do an X-ray, we can compress that X-ray and then send it for interpretation very quickly. So we're doing that for CTs, X-rays, ultrasound, and that's why we need a dedicated line. So the increase of 138 million addresses the concern there in terms of paying for that service. This year, we are also going to introduce a PAC system because we have a number of digital X-rays that we've set up across the country. So all of them are now going to be interlinked in one system. And during the budget speech, I spoke about AI platform that we have been piloting, and now we'll be deploying it across the system. What that would do for us is that when you do a chest X-ray, for example, you put it into the system, and within 17 seconds, it will tell you whether it's normal or abnormal. And if it's abnormal, it takes another minute to give you a tentative diagnosis as to what that might be, what are the abnormalities. So by the end of the year, we want to link all of our X-ray facilities to this system so that we can have the interpretation done very quickly. We are also going to do that for CT scanners. We'll do it later on for mammography. We'll do it for ultrasound. So having dedicated line is very important for us to operate such a system.
Thank you very much, Minister.
Honorable Member, Mr. Mahipal.
Thank you very much, Mr. Chairman. And I am looking at Volume 2, the Program Performance Statements. And the objective is to ensure that the Guyanese public has access to equitable, accessible, technically competent, and socially acceptable primary health care. And sir, I'm about to touch on what I will consider a bit sensitive matter. I want to first acknowledge, sir, that my experience at GPHC, I have seen tremendous improvement in terms of the equipment and the service in terms of the way the staff communicate and so on. And I want to congratulate the CEO for a job I think he's doing exceptionally well. A fellow Essequibian, by the way. But my concern, sir, has to do with the complaints that are coming from the poor and vulnerable of society. Oftentimes when they go to not only GPHC, but several other hospitals, they are not being seen by doctors. And upon investigation, I found out that several doctors don't work for what I will say an 8-hour shift in the public system. And these poor and vulnerable people will oftentimes have to go to private clinics. And sadly, when they go to these private clinics, they would see the very doctors who are supposed to be in the public system administering health care to them there at the public facilities, where they will have to pay huge sums of money. And I think it's an unfair and unfortunate situation that requires addressing at the level of policy. So I would like to ask the Honorable Minister, in the act of putting people first, what measure will the ministry take to ensure that there is this move to curb private practice to the extent where the amount of time a doctor is to give to the public service per day is at least adhered to?
Honorable Minister.
Thank you very much, Mr. Chair. Which line item you were under?
I was dealing with a policy, I'm in volume 2, looking at the policy statement that speaks, Mr. Chair, to the objective being to give equitable, accessible, and technically competent primary health care on page 231.
Volume 2.
Which program? It is a valid question.
Okay, I'm trying to figure out where it is, but
I think, sir, it's a matter that I think we can.
Yeah, I think the honorable member raised a very valid concern.
Thank
that is, we have doctors who are employed full-time in the public sector, but they also moonlight in the private sector. And we have to pay them well. They are being paid well. You might be surprised. You might be surprised. They're being paid very well. But it is something that we have to look at. It's not a problem that happened overnight. This has been a perennial problem for us. And I think we'll have to figure out a way of how we can mitigate this. There have been several systems that have been suggested, that some of these doctors can work part-time in the public system and maybe work part-time in the private system. Or we have to come up with a different model. Now, I think one of the things, especially the Georgetown Public Hospital, that we would see some changes during this year where the different people who are managing the patients would have to sign off on the patients. So by putting in the electronic health record that is now being implemented at the Georgetown Hospital, when you discharge a patient, so all that record that is there, you will see which doctor saw the patient, when, how much time they spent with the patient, and when they discharge the patient, you would also get that. So if they are not in the system, if they come in and spend an hour and disappear, then all of that, you would be able to track that. And I think that would bring some level of accountability. So that's one major thing that we are putting in place, and I hope that would help us to manage this problem better. That's one. You talk about when patients come, we also have another problem sometimes. When patients come to the hospital, somebody who is not necessarily medically trained would sometimes turn patients away. And this is something that we have been working to prevent. And we are now training, if you have a security service that is providing service at the hospital, we train them to make sure that they don't turn people away. And we have introduced something starting with these 6 hospitals where we have patient advocates. Now, we have recruited these people, we have trained them, so when persons come and they're sitting waiting, sometimes they wait there, and if nobody is interacting with them, they don't know what to do. So a patient advocate, I'm sure when you go to Walmart, you see these people with a nice
blue and yellow,
and they got a nice smiley face, so we're trying to introduce something like that. They'll come to you, they'll ask you if you're getting through, if you got a problem, and try to see how they can help you to manage your problem. We hope that this would work, but at least we're trying to respond to some of the calls that we're getting. And hopefully, as we all work together, we'll get the system to be much more responsive. I want to also mention this too, because people would show up at an accident and emergency, and they are not non-emergent cases. Or, you know, they got a cough and cold, you show up at emergency. An emergency is for people who really need urgent care. And sometimes when you try to separate that, the non-urgent patient from the urgent ones, people feel that they're not getting good service. So in the light of that, what we have started to do, apart from the accident and emergency, we are running an urgent care clinic. So those who come like after hours, because there might be a mother with a child who got a runny nose, didn't have time during the day to come to the hospital, but after she comes off of work, she would come there. Then we have a clinic where you can go and you'll get those problems addressed. And we're trying to put those systems across the different hospitals. So the non-urgent patient would also be seen. But a lot of times, a lot of non-urgent people show up at the emergency and they can clog up the system. So we're aware of some of the issues and we're trying to work with very pragmatic solutions to solve them. But we also need the help of the community. Another problem that we're seeing too is that where we have put in some of the hospitals, people are bypassing the health center. So they no longer want to go to the health center, they go directly to the hospital. That too can create a lot of congestion in the hospital. You have your primary care facility that is next to you, go there. If they need to refer you, they'll refer you in. So we all got to work together to make the system work better, because we have deployed people at different levels of the system that can bring care to people quickly.
Sir,
Thank you,
a
Minister.
follow-up,
Honorable Member,
please.
Mr. Mahipol, and I have the Honorable Member Amanza, Walton Desir, I have Dr. Campbell, Ms. Finance just put on her.
Can I have one
mic,
follow-up?
And then we have the Chief Whip for the opposition. I'm just
Yeah, thank you.
letting
One
people
follow-up.
know that they have been recognized by me so far. Go ahead.
Thank you, sir. Sir, may I ask the Honorable Minister, is there an amount of time that is standard for all doctors to put in per day at all these public hospitals, or does the time vary based on the category of doctors that we have?
Minister?
Thank you very much, Mr. Chairman. Thank you very much, Honorable Member. I think that's a very good question. When we employ people, we employ them to work the 8 hours.
8 hours.
Right? So that's a standard thing, and then you have overtime and so forth. So there's an on-call. So these things are established. Unfortunately, sometimes people don't adhere to what is in their contract. And the same goes for nurses and other technical people.
Thank you, Mr. Chair.
Thank you very much. Honorable Member, Ms. Walton Desir.
Thank you, Mr. Chair. Mr. Chair, line item 6221, drugs and medical supplies. Mr. Chair, there is an almost $9 billion allocation there, and so we're allocating significant resources for healthcare across the system. Could the minister explain the system currently in place for inventory management and stock rotation, etc.? The monitoring of expiration dates to ensure that medicines procured remain safe and usable. How do we prevent expired medication from getting to our citizens?
Minister?
Thank you very much, Mr. Chair. Thank you very much, Honorable Member, for that question. So, first of all, what we do, we start the process by trying to do a demand, to understand our demand for medicines. We procure right now we procure close to 4,000 different items. So medicines plus medical supplies, lab reagents, so close to 4,000 items. Of those 4,000 items, about 1,000 of them are the ones that move very quickly, and therefore we need to make sure that we have them constantly in stock and to be able to get them out. Once we have this demand generated, we go out to procurement, we buy, we bring it into the system. They go to the MMU, the Materials Management Unit, and from the Materials Management Unit, regions can then request their meds, whatever meds they need, and we are able to send those meds to them. We recognize that some regions, they don't have the capacity to maybe store. So one of the policies of the government now is to make sure that we build regional material management units. So at least for the big regions, they will have their own material management units. We have 5 such units that are currently under construction. By the end of the year, they would all be in operations. Now, what we'll then be able to do is to decentralize the supplies and send them out to the regions. And from those regional units, they would supply their respective health facilities within the region. So that's the way that we want this to operate. Right now, it has been a system where the regions would request medicine, and then we have to pick it, pack it, and send it out to the region. So that's a kind of pull system. What we want to go to is a push system, where as soon as we get it, we send it out to the regions because we'll now be able to know their demand, and so we send it directly out to them. So that should be more efficient. The whole system that we have had over the years, when medicine go out, and if it go out to, let's say, a health post or a health center, and it's not consumed, it will remain there and expire. We want a system now that is different, that is nimble. So if we would know every medicine that we have in the system, what is the expiry date? So if we recognize that in one region there's Panadol, and it got maybe 2 months more to expire, and another region they don't have any, we would be able to pull that back and send to that region so that we will maximize the consumption of the medicine. That's the system that we are moving towards. Now, to get us there, that's why we have employed this team from Ernst & Young. That they have been helping us to put this system in place. We have had a piece of software at the MMU that has been there for more than 17 years. And we are updating that. So we're going to put in a new software that would do modern warehouse management. And while we start at the MMU, at all of these regional bonds, as we build them out, we'll be putting this system there. And all the big hospitals where there's a big consumption, they would also have this system. Eventually, every single health facility that we have would be on this electronic platform. Now, that's one aspect with the medicine. We are building out, parallel to that, we are building out the patient care record. So every patient would have their electronic health record. As I said, we are starting at Georgetown Hospital. But this then would go across the entire system. And we would then, at some point, be able to merge the two things. So when a patient, if they're diagnosed with hypertension and they got to get medication, we can actually track to whom this medication went. So it would also curtail leakage in the system. Right? So this is a work in progress. We have started. It's very ambitious. It was never done before, and we are working on it. So we anticipate there are going to be challenges. There are going to be problems. There are going to be hiccups. But I think this is going to be good for the entire country once we can get this up and running. And that should be the goal here, to try to make sure that this is up and running.
Thank you, Mr. Chair. Minister, thank
Go
you for
ahead.
that, very detailed explanation. And I really do support us bringing this on stream as soon as possible. The question remains, however, in the interim, how do we make sure that we minimize these incidents? And it's a two-part question, and I'll give you an example, and I'll ask the question. I've received complaints from the Port Morant Hospital that there are eye drops there that have expired. When you check the boxes, and I'd be happy to share it with you, you'll see that it has a 1-year shelf life. My question is, do we have a system in place to make sure in our procurement system that there is enough time to for procurement, as you said, distribution, to make sure that that is built into when we procure, so that we're not going to procure. In other words, what are the timelines that or do you have the timelines, let me put it that way, built into the system of procurement to make sure that by the time the drugs arrive in Guyana and that they're ready for distribution, that there is some shelf life left within the time span?
Honorable Minister.
Thank you very much, Mr. Chair. Thank you very much, Honorable Member. I think that's a very important question. So in the contracts that we have with our suppliers, upon delivery, the product must have 80% of its shelf life. So that then allows us to bring it into storage and then to send it out to the persons who are going to consume the meds. So that's what we've been working on. And all of our contracts, it states that.
Final follow-up, please,
Go
Mr.
ahead.
Chair, on this. And, I'm happy to hear this, Mr. Minister. I want to maybe encourage that we monitor very closely the performance under these contracts, because I raised last night with the Honorable Member Manik Chan that I received reports that Ministry of Health workers were in Region 6 as well, distributing cleaning agents that expired 3 years ago in 2023. Again, this is information I'll be happy to share with you. So it appears to me that there might be some disconnect between what the framework should be and what is happening on the ground. I suppose in any system that is possible. I really do just want to encourage stricter maybe enforcement and having a look at that. Thank you, Mr. Chair.
Honorable Minister, is this one swallow summer?
Thank you, Mr. Chair. Thank you, Honorable Member. You would recall that during COVID, one of the things that we were concerned about is to make sure that we have adequate supplies. We did buy a lot of supplies, right? We did buy a lot of supplies because then the market was, you didn't know whether you were going to get it or not, so we bought. And one of the things that we actually bought a lot of was these cleaning agents. And so right now we have a lot of the cleaning agents, and we have been sending them out to different places, hospitals. We have given some to the markets and so forth. Now the cleaning agent, the potency of the cleaning agent has not changed, right? Because we had persons test it, and it's the same. Now this is not something that somebody is consuming. It is for the environment to clean and so forth. So rather than dumping it, we feel that it would have use value in terms of using it to clean the environment. And that's what has been distributed. So it's not only in Region 6, we have been sending them out to other regions and to make sure that they use it. Same thing, we have spoken to some of the people who are running markets. We have been giving them to them. Some of the schools, we have, if they need the cleaning agents, we give it to them. So it's there and it can be utilized. and that's what we've been doing. Now, I know in the discussion that when we were having the debates, one of the things that was raised was a lady who, from New Amsterdam, who said she had expired oncology medication. So I treat these things very seriously because when people raise them with me, I want to know whether this thing is happening or not. I went back, I looked at the case, I got the information. She was given medication in November, and the medication expired in January of the following year. So at the time when she came to the hospital in January, the medication was about to expire. So at the time that she received it in November, it was still valid. Now, what we want ideally is when our patients come, whatever meds they're getting must have a long expiry date. That's what we aspire to. But in this case, she did not receive expired medication. She could have consumed it before because of the time frame and so forth, but our ideal desire is to make sure that people get longer dates. But this case, it was a narrow window, and if some remain, and I'm told that some actually remain, she came back to the pharmacy and they collected that and they give her one with longer dates. So that problem was rectified, and that's more of an exception rather than the rule.
Thank you, Mr. Chair. Through you, sir. I'm just looking at the program performance statement. I'm looking here in volume 2, just for a bit of a policy question, sir, that I think is very important. We see here the impact that is outlined here is for medical norms, standards, and protocols are upheld at the regional level. And I want to say from the onset, a lot of times some norms that is at the hospitals may not necessarily be something that comes down from the head. So for clarification on this particular matter, when it comes to patients' right to their medical information, is there a policy, a norm within the system that says a patient is not permitted, for example, to take a photo with their test results from any public hospital in Guyana?
Minister?
Thank you very much. That's the patient's right. It's their information. They must have their information. So it's not, they shouldn't be denied their information. That's their information. Now, it's going to become even simpler for patients because the electronic health record system that we're putting in place, you will have an app on your phone and all your information would be at the tip of your finger. So basically you can go there and you can access your information. And when you present yourself for an appointment, you don't have to, because one of the challenges that we have, right? When people come for their appointment, they'll take a long time maybe to find the chart, and so persons have to wait. We are moving to a system where we want, you go online, you book your time, you turn up maybe 10, 15 minutes before, and you go in to see the doctor. You don't have to wait excessive amounts of time. And your chart would basically be electronic. So you'll have it either on your phone, the doctor would have the chart on the computer, and you'll be able to access your information. Now, if you want to move, let's say you want to move from the public system and go to the private system, that information is with you. So the portability of the data is there. And that's what we want people to have, because it's your information. And the system that we are building, when you go see the doctor, the outpatient, whatever they are prescribing for you, it would be an e-prescription that goes to the pharmacy, and it would also be in your patient history. Because a lot of our patients, sometimes they don't know the names of the meds, but it will all be listed there so that you can see it. If when you go to the outpatient, they take a blood sample, right now, when they take the sample, you have to probably go to the lab for them to take the sample. We are changing that. They'll take the sample, it goes to the lab, you don't have to go back and sit there and wait for the results. Those results, once they're ready, they go into your patient record. Same thing with imaging. If you take out an x-ray or something, it goes into your record. So all your record would be one place, and you would have control. And in the law that we pass here, the data protection law, one of the things that you can decide the level of access that you want to give to somebody in terms of your information. So you can determine whether you want this person to see everything or half of it or whatever. That's in the patient's control. And that's very, very important. Right?
I thank the minister for that response, and I want to say that I fully support that bit. And in the interim, what I would ask through you, sir, is that maybe a little bit of an internal memo be circulated in that regard, because there are very many cases in which patients are denied taking a photo of their medical information at various hospitals. So I think that would be useful in the interim as we await that more advanced system. Thank you.
Thank you, Honorable Member. Mr. Campbell.
Okay.
Thank you, Mr. Chair. And thank you, Honorable Minister, for following up on the case for New Amsterdam. In this regard, you're perhaps exceptional amongst your peers for actually listening to what was said. I have two quick ones. One, I want to read very briefly. This was the end of December. It says, Minister of Health Frank Anthony has underscored the urgent need for improved accountability, strict adherence to clinical guidelines, blah, blah, blah. And I'm asking this in line with the policy, again, just referenced by my colleague, medical norms, standards, and protocols. And I want to tie this to a couple of cases that, again, I'm sure you listened to. Can you share with us what improved, how are we looking to improve adherence to protocols? Because there have been some really sad cases recently.
Honorable Minister.
Yeah. Thank you, Mr. Chairman. Again, I know during the honorable member's presentation, I have the list of all the people that you mentioned. I wouldn't go through them. But maybe just a highlight of some particular things with them. First of all, we want to ensure that people follow guidelines. So we have to establish those guidelines. So we're setting them up in diabetes, hypertension, cardiovascular disease, oncology, a whole host of them. So that's the work we're doing with Mount Sinai. Once we have those guidelines, we are training people to prescribe using those guidelines. And then we want to monitor adherence. So within the ministry, we're setting up what we would call a quality audit. And we'll be sending out specialists to go to various hospitals, and they would pull charts randomly and examine to see whether these guidelines have been adhered to. And if they're not adhered to, they'll work with the medical team, because we don't want this to be punitive. We want, first of all, for people to comply, that they're doing the right things. And so we will be doing that and monitoring people and teaching as we go. And we hope that that would help to improve the standards. While we're doing that, we are also working with JCI, and we're on their pathway program. JCI is the Joint Accreditation International. Now, what that helps us to do is that they have a whole set of indicators that you have to comply with. And we want to make sure that we are on that pathway to make sure that the quality that we're delivering at our hospitals meet those standards. So this is another thing that we're doing to improve quality in our healthcare system. Now, over the last year, we have had 11 maternal deaths. That has come down from 22 maternal deaths maybe 6-7 years ago, right? So we are making progress. When we examine some of the cases, they could have been handled differently. And each one of these cases, we had the Maternal Mortality Review Committee that went through them. And in some of the cases, they have been recommended to go before the medical council for disciplinary action. And so that some of these cases have been sent there, and the medical council would take the requisite action. The action that they have ranges from maybe sending them back for retraining to striking them off the register if they find gross negligence. So those cases are there. We have our own views of what happened. I don't want to be the arbiter of what happened. That is for a professional team of people to do that, and that's where it is. One of the cases that was referenced of a young child that had a kidney removed, and as it turned out, the child had one kidney. Now, you had a whole set of experts that got together, and at the time, the best judgment was that they thought it was 2 kidneys, and one was infected. And to save that child's life, they had to do the intervention. So they went in and did the surgery. And then afterwards, they recognized that it was 1 kidney. Now, the team, we have put them under investigation. There's a report that is pending. And when that report is completed, relevant action would be taken. And it's being reviewed by overseas experts as well. So we don't treat these things lightly. Some of these things are very, very complicated. They're not your usual run-of-the-mill kind of cases. They're very complicated. In this one, from all that I have seen, it looks very complicated. And when they were doing the case, they were doing it with the best interest of that child in mind. But these things happen. We have to learn from them, and we have to move on. So each one of the deaths, especially maternal deaths, we review them and try to learn what went wrong and try to fix it. Because we want to bring down our maternal deaths so that we're below 70 per 100,000. That's the WHO standard. We want to go even way below that. And that's what we're working towards.
Mr. Chairman, follow up, please.
Follow up. Go ahead, Honorable Member.
Honorable Minister, I'll try to stick to and quickly because you seem to be the most in-demand minister right now. So, one, in relation, again, to standards and protocols. In relation to nurse training, I've done some checks, and it seems it's all local. I know the rest of the Caribbean is using the CXC, Regional Nursing Examination. So the first question, I'll just give them both to you, and then I'll yield. The first question is there any special reason why we haven't signed on to that platform so we are assured of accreditation and standards? And the second question, perhaps a little more difficult, is line item 6221, drugs and medical supplies. I know historically the last report said 58% from new GPC. The question is, are the drugs all tendered now, or is there still sole sourcing going on? And what's the current level of supply by new GPC? And I'll yield after this.
So all the drugs that we buy, we tender. So there's a public tender. When we finish this process, we go to public tender, and there are companies that bid for it. And whoever wins, they get the contract and they supply. So that has been the modus operandi. We have to acknowledge that GPC is one of the biggest pharmaceutical companies in the country, and they have been winning a lot of the contracts. In the past, you had IPA, I think, I don't see them bid anymore. I don't know if they still exist. So they used to be one of the players in the market. I don't think they're there anymore. You also have Western Scientific. That's another big player. They're still around. They do most of the medical supplies, right, and lab reagents. So you don't have many. So of those that you have, these are the ones who would obviously win, but it's open. It's open for people to tender. So that's the first one. The second question that you ask about nurses and nursing training. We have, in the past, our way of training nurses would have been they come to either one of the 3 schools that we have, either at Linden, Georgetown, or at New Amsterdam. And we were only able to train maybe about 200 nurses in any given year. These programs are 3-year programs, and with 200 nurses, it would not fill the needs that we have. We have developed a new program. It's called the hybrid program. And this program actually was developed in partnership with the World Health Organization. World Health Organization would have given to PAHO $1 million US, and they gave that money to the University of San Pablo, and their nursing faculty has been working with us in Guyana to develop the hybrid program. And the university in San Pablo is a WHO collaborating center. So all the professors from there came down to Guyana and worked with our team, and then it took our tutors, about 30 of them, to Brazil and immersed them in how they teach. And so we have designed an entire curriculum, 3 years of this nursing program, and we then decide to partner with Coursera. So this content is on the Coursera platform. So rather than invent how people are, the appraisal systems and all of that, it is using all the tools that Coursera has. And so this now has become a model. We'll have, by June of this year, the first batch of close to 800 registered nurses that would be graduating. Now, when you're doing nursing, you'll have the theoretical component, and so that is being done on the platform. And the practical component, what we have done is to build simulation centers across the country, including putting in mannequins and all of that, so that we can bring the nurses into these simulation centers and train them on the practical component, and then we expose them in the hospital. So this has been an ongoing thing, and this model has been working really well for us, because having 800 people graduating this year, that's going to be a big boost to our healthcare system. And then later on, we'll have another set of people that would be graduating. So we expect that this year alone, we have, for different categories of training that we're doing, not only nursing, but different categories of training, close to 5,000 people who would be coming off different programs, and we'll have to bring them into the system. So it would strengthen our system. In terms of the accreditation, Guyana has always had its own system of accrediting our nurses. So we haven't joined the Caribbean nursing body, but we participate in their sessions. And right now, this hybrid program, because every country in the Caribbean, they got a nursing issue. And a lot of what they have tried have not worked for them. And so we have now quite a few requests for people wanting to join this hybrid program that we have put in place. And very soon we'll be signing some agreements where we'll allow some of the other Caribbean countries to join this online nursing school that we have. Another positive thing with this program that we have set up, we now have 130 telemedicine sites in different parts of the country. Many of these sites are in small communities, maybe 500, 600 people and so forth. But for the first time, apart from doing telemedicine there, persons who are living there and meet the qualification requirement, like 3 subjects CXC, they now would have an opportunity to get online, go to one of our courses, enroll, and participate. And so a lot more people in the interior of Guyana now have a chance of staying in their community and getting that education. And it's making a big difference.
Mr. Chair,
I'm taking Miss Halley, I'm taking Mr. Solomon, I'm taking Miss Amanza Desir Walton.
Thank you, Mr. Chair. 2 questions, one based on what the Honourable Minister stated earlier about the doctors. I was just wondering what's the lowest salary a doctor receives and the highest?
That's for GMO.
How much?
The consultant is all.
I know it includes specialized and all of that, but I would just want to know what the...
So the lowest a GMO would receive is about year 1, $455,000. That's your starting salary. And if you're a consultant and higher, you get more than $1 million.
Okay. Thank you. So I'd like us to move to 6321, which is GPHC. And if the Honourable Minister could state whether maintenance of infrastructure at Appendix T includes the equipment at GPHC.
Minister?
What, Mr. Chair,
Go
can
ahead.
the honorable member say what equipment?
No, I was asking, 6321, so we're at Appendix T now for GPHC, and I was wondering whether the maintenance of infrastructure includes the equipment, the medical equipment at GPHC.
Yes, definitely.
Thank you. So can the Honourable Minister please state whether currently the ultrasound at GPHC is functioning? Because we tend to have a lot of feedback that people go there, but the ultrasound is never working. So is it currently operational? Does it need servicing? Do we need a new ultrasound? I'm done.
Honourable Minister.
The ultrasound at the Georgetown Public Hospital, and we have several.
Okay.
They're all working. The challenge that you might have is that depending on the volume of patients, people are given a date to come back, right? I had some figures somewhere. It's literally thousands of people that we do ultrasounds for.
Thank you, Mr. Chair. Honourable Minister, I understand your response, but sometimes the feedback that we get is that persons are told to go to a private clinic to get the ultrasound done instead of being able to do it at GPHC. So I was just wondering, you said you have a lot. I don't know, right? You said you have a lot, I understand that, but I just bringing that to your attention that sometimes people, when we go in the communities and we walk in, they say that they've been told to go to a private center instead of a GPHC, just so you note.
Honourable Minister.
Thank you very much, Mr. Chair. And I want to thank the honorable member for that observation. Now, what I want to say to the general public, if you come to any one of the hospitals, anywhere, and somebody say to you, you can't get it done here, but come to my private clinic, report them. Report them so that we can have the information and we can deal with them. Because it's not only for maybe these, let's say ultrasound or whatever it is. It can also be that people, they recruit patients from the public sector. So we don't want that. We have invested a lot of money in our public system, and there's no reason why people can't get care in the public system. And I want to say this too. Some of the facilities, for example, that we have at the Georgetown Public Hospital, it is the best that you have in the entire country, right? It's the best that you have. And the CEO is whispering to me, he said, in some cases, it's the best in the Caribbean. But we have very good facilities, especially our ICUs, right? Our ICU is extremely good. The cardiac services that we are offering is extremely good. And there are a whole host of other things that we have put in place. So the general public should benefit from these things. And they shouldn't be told to go privately when we can do it.
Thank you, Mr. Chair. Just a final on this. I thank you, Honourable Minister, for your response. And I note that you spoke to the general public on how they must deal with it, but what is the process for them to let somebody else know that this is what they're facing when they get to the hospital? Who should they contact? How do they report it?
Honourable Minister.
Thank you very much, Mr. Chairman. So I would say there are two ways. At the Georgetown Public Hospital, they have a help desk that you can go there and complain. But more importantly, go to the CEO office. They're right behind me, but go to his office and make that complaint so that we have it documented and we can deal with it. So that's one way. For the general system, we also have a hotline that we have developed. So people can use that and complain to us. And every day, we have a summary of complaints that we receive, and the person who is manning the complaint desk, they would then try to resolve them, and if they don't get it resolved, then they move it high up the chain. In some cases, people would call and they'll tell us this hospital, whatever it is, and we try to make sure that it's fixed. We have also put up at all of our health facilities a poster, and it got a number. So if you go there and the place is supposed to open at 8 o'clock, and whoever is responsible for the place didn't come to work, and the place is closed, call the number so that we know and we will be able to take action. So at all these health facilities, we have put up that. And I'm sure it's on our website as well.
Thank you, Minister. Honourable Member, Mr. Solomon.
Thank you very much, Comrade Chair. I just want to thank the Minister for the emphasis that they're placing on training and recognize that we have so much in terms of patient care from nurses. But just a quick follow-up on the training aspect of the Charles Rosa School in Linden. I know there have been some concerns in terms of its functionality. Can you justify for those concerns what actions were taken that would have reduced the school in terms of how it would have distributed or at least trained nurses for the public?
Honourable Minister.
Thank you very much, Mr. Chair. Thank you very much, Honourable Member, for that question. I think there was some confusion with Charles Rosa. So I'm happy that you're giving me this opportunity to clarify whatever misconception people might have had there. Charles Rosa, like any one of our schools, should train for the whole of Guyana. It is not a school just to train people from Linden alone. And several years ago, you had an intake of about 30 people, if I recall properly. And at the time, they wanted everybody to be from Linden. And we said, no, you have to get people from some of the other communities to also be allowed to train in Linden. So we brought in people from different regions, Region 9, Region 7, Region 8, and so forth, and they were all able to go to Linden and get training at Charles Rosa. Somehow, that was interpreted as if we had closed the program. It was never closed, right? So Charles Rosa is up and functioning, and we have been expanding Charles Rosa. About 2 years ago, I was up there where we gave additional teaching aid to the school and to ensure that they are able to use this type of teaching aid. Right now, just behind Charles Rosa, we have a building that is going up there. I visited the building maybe about 3 weeks ago, and maybe in another month or two it would be completed. That building is specially dedicated to it's a simulation center that we're building, specialized simulation center that would allow for practical training for the nurses that are being trained at Charles Rosa right now. So it's not about closing the school, it's actually expanding the functions of the school and to ensure that more people can get training at the school. As we speak right now, the head of the training division in the ministry, she's just given me some numbers. We have about 220 persons from Region 10 that are in training. We have, in terms of nursing assistants, batch 1 and 2, we have 171 persons that are in training right now at Charles Rosa. We have single train midwifery. We have 30 persons who are being trained at Charles Rosa. So a lot of people getting training and a lot of people getting the benefits of these training. And once they complete their training, the government has given an undertaking that we are going to employ every single person that we have trained. So 220 persons would soon be employed from Region 10.
All right, thank you very much, Comrade Chair. Just a quick follow-up to the Minister. The period in between the, what you would call reorienting what the program is or the institution, were there any obstruction to persons who would have graduated? Was there any period of intermission where people were not allowed to graduate because of that redesigning of the purpose of the institution to cater for a wider?
Thank you, Mr. Chair. And thank you very much for that question. As far as I'm aware, it didn't take a long time. And you know, the intention for that school was always to train people from different regions. That was the intention all the time. Whether we were in government or PNC was in government, that was the intention. Right? So we didn't do anything abnormal. This is the normal thing. Right? And there wasn't any interruption. Nobody, their graduation was not postponed or anything of the sort. Right? So I just want to say, the bottom line here is Charles Rosa is up and running, and more than that, we are investing in expanding the school so that more people can benefit from training at Charles Rosa.
Thank you very much, Comrade Chair.
Thank you very much, Honorable Member. Ms. Amanza Walton Desir.
Thank you, Mr. Chair. Just a quick follow-up on the impacts and spinning off of what the Honorable Member Finance asked. Minister responded by indicating that, and correctly so, that there's a Data Protection Act. What I wondered, well, let me preface it further by saying that, of course, that Data Protection Act is a general shield for Guyanese and their personal information. Are there plans, Minister, to have a drill down in terms of regulations specific to the medical industry, for example, in the likes of HIPAA in the US? And are we contemplating legislation that will penalize institutions where access is gained to persons' medical information and that is broadcast, etc.? Are there those plans in the pipeline?
Honorable Minister.
Thank you very much, Mr. Chair. Thank you very much, Honorable Member, for that question. Under the Data Protection Act itself, there are penalties. So for a person, if I recall correctly, because we all were here when we went, no. So if there's a person who leak someone's information, so breach confidentiality, I think the fine is it starts at 20 million Guyana dollars. Right? If an institution breach confidentiality and leak your information, the starting fine is $100 million. So it's there in the law, and what we have to do is to implement it. And part of when we brought that law was that we were contemplating the implementation of the same electronic health record, among other things. And it was important that people understand that their information would be protected, and if anybody tried to breach that they would be held responsible and they would face severe penalties. As it relates to specific health regulations, in the ministry we have already started to work on specific health regulations, and at the appropriate time we'll unveil those.
Thank you, Minister. Honorable Member, Ms. Natasha Singh.
Thank you, Comrade Chair. Comrade Chair, I'd like to follow up on my colleague's question, Comrade Solomon, on the nursing schools. My question is specific to the school in Linden, the one in New Amsterdam, and the one in Georgetown. Where are we in the process of registration with the National Accreditation Council? Because I understand that accreditation is a whole different story, but I know registration is mandatory.
Honorable Minister.
Thank you very much, Mr. Speaker. The accreditation, the ministry has always accredited these programs. So since the inception, we have been accrediting our own training program. I know the accreditation body, they have been looking at accreditation for medical schools. But many of those, what they do is that they're able to offer accreditation for the administrative aspects of it, and then to be able to issue a license to start. But the ministry has always been accrediting its own program, and it might surprise you, we have more than 20 different training programs that we run. And we are in close partnership with the University of Guyana. So that's for the program directly in the division. We have some other programs that we're running, this postgraduate training, and that is run in collaboration with the University of Guyana, the Georgetown Public Hospital, and the ministry. Those postgrad programs, they include about 18 different specialty programs for doctors. And another very good thing is that we are now seeing a lot of Caribbean doctors coming to Guyana to get training. So whether it's in orthopedics or surgery, they're all coming now to get training by us.
Thank you very much, Comrade Chair. One last follow-up.
Go ahead.
So, Dr. Frank Anthony, the National Accreditation Council Act speaks to mandatory registration for institutions that offer post-secondary institutions. I remember prior to 2015, I can't remember the exact year, Charles Rosa was registered and Georgetown was registered. Not sure if New Amsterdam was completed. And so I know that the institutions would have started, they would have had a number of recommendations to be implemented to meet the non-academic standards of offering post-secondary education. And so I'm not sure if you were brought up to date with that. But the accreditation, according to the Act, program accreditation is not mandatory. But the institution itself has to meet certain non-academic standards, and I know they started. I'm not sure if they were completed, and so that's why I asked if they were, what stage it was.
Accreditation from the
Tha-
accreditation expert.
Yeah.
Honorable
Tha-
Minister.
Thank you very much, Mr. Chair. I thank the honorable member for the observation, and I'll check with the team to make sure that if we need to be compliant, that we would be compliant.
Honorable members, this has been an intensive, extensive, and exhaustive probe onto the monies for clinical services, and I now put the question that the sum stated for program 474 current expenditure stands part of the estimates. Those in favor say aye. Those against say no. Ayes have it. Sum stated now stands part of the estimates. Honorable members, I now put the question on 474 capital, which is contained in pages 538 and 539, and I propose the question that the sum stated for agency 47 program 474 capital stands part of the estimates. The honorable member, Ms. Tabitha Sarabo Hali.
Thank you, Mr. Chair. Mr. Chair, I would like us to turn to 440-5600. Mr. Chair, based on volume 3, it says that the design, construction, and equipping of the pediatric and maternal hospital is under this line item. Can the Honorable Minister state what percentage of works have been completed at this stage?
Minister.
Thank you very much, Mr. Chair. Thank you very much, honorable member. At this stage, we are about 60% complete.
Thank you, Minister.
Thank you, Mr. Chair. Can the Honorable Minister state how much monies have been allocated this year for the project?
Minister.
Just give us a sec. We're trying to get the number. Maybe you want to go on to the other question you want to ask while we look for the number?
It's the same project though. What was the total sum for the entire project? I wanted to know that as well. And the completion date?
Let's take Dr. Campbell as the technical staff provides the information or retrieves the information. Dr. Campbell.
Thank you, Mr. Chair. Honorable Minister, 440, project code 440-5600. I notice it says IDB, UK, Sweden, other. I don't see Austria. I'm looking in particular for the maternal and child health hospital. It's the same, okay. And the New Amsterdam hospital, does it fall under the same code?
Yeah.
So, all right,
So-
we have similar questions.
So then let me, so the one that you're looking at, that's for New Amsterdam. So the company that is doing the construction is Vamed Engineering. The financing for New Amsterdam is coming from Sweden. And so that project deals with New Amsterdam. The pediatric hospital, this one is again being done by Vamed Engineering. And the financing is coming from the UK. So that's for the pediatric hospital. I think, Honorable Member, we have 8 billion that is assigned for this year to the pediatric hospital.
Thank you, Minister.
Thank you, Mr. Chair.
Ms. Halley?
The question, how much has already been given to the contract, to the contractor?
So far for the pediatric hospital at Ogle, we have given to the contractor 100 million euros.
100 million euros?
Yeah.
And what I had asked earlier, what is the total cost of the project?
The total cost is 149 million euros.
Thank you, Minister.
Follow-up, sir.
Go ahead, sir.
Would the Honorable Minister say that this project, you have given 100 million euros. Visual evidence doesn't suggest anywhere close to 100 million euros in construction. Would the Honorable Minister say that this project is in some kind of trouble and requiring maybe a legal intervention?
Minister?
Thank you very much, Mr. Chair. This project has been delayed, and we have engaged a contractor, and part of the problem has been that, first of all, we started this project with the Austrians because the government of Guyana at the time and the government of Austria signed an agreement in 2018. And in that agreement, government of Austria agreed that they're going to identify, we had 2 projects at the time in 2018, Georgetown Hospital and the Diamond Hospital. That was subsequently changed to do a pediatric hospital. And the undertaking out of that agreement is that the Austrian government would find an Austrian company to be able to do this construction. They identify Vamed. So at the very beginning stage of all of this, we were always dealing on a government-to-government basis. The Austrian government had a majority stake in Vamed, and at some point over the last couple of years, they decided to sell their stake to a company called Fresenius, the manufacturer of dialysis machines. And when they sold their stake to Fresenius, Fresenius became the sole owner of the company. And I think that caused some of the delays that we are experiencing, because new management, new whatever, a private company now. And then to compound the problem, Fresenius then sold the entire Vamed to another company, a German company. And so right now we are dealing with that German company who's the new owners of Vamed. And we're negotiating with them now to finish the project, to make sure that all that was listed in there, that it's completed and done in a realistic time frame. So these things, they happen. It wasn't foreseen. And we have engaged the Austrians, the Austrian government, whom we started out with this MOU. And they have also been ensuring that the company deliver what was promised in the MOU. So that's, yes, it's delayed, and we need to make sure that we get this project completed. And so we have been engaging with them. We have had several discussions with the new owners. They have been here. We have talked to them, and they have come up with a new schedule of when this project can actually be completed.
Thank you, Mr. Chair. One final follow-up.
Go ahead.
What's the expected completion date on New Amsterdam now and on the pediatric hospital?
So both of those, our engineers and VAMED is currently on discussion on finalizing the plans for both projects. And once that is finalized, we'll let the public know where we go from there.
Thank you.
Thank you, Minister. Honorable members, I now put a question that the sum stated for a program.
Sir,
Honorable member, Mr.
to Andrews.
Go Andrews.
Thank you, Mr. Chairman. Honorable Minister, line item, project code 1216200. There's a provision here for $6 billion. This project, duration is 5 years. Do we anticipate early completion of this project? This is going to be year 3 for, pardon? Reference 206. Okay, the code is 1216200.
Minister?
So you want to know the projects that we have on the
no, in the interest of time, if you prefer, you can lay that over. But
no, I just want to know what exactly, so I can explain to you.
The question is, do we anticipate for this? Because when we go to reference 206, do we anticipate it's a 5-year duration? Do we anticipate that we're going to have an early completion of the entire project?
So under that heading, right, they got several projects. Among those projects, they got like the nursing schools that we're building. So one of the schools would be in Escribo, one in New Amsterdam, and they have a whole set of other projects that are listed under that heading. The nursing schools, by the next couple of months, those should be finished. So it's not all that would go until maybe 5 years from now, right?
Okay.
So there's a list of projects and they have different completion dates.
The reason I asked is because I noticed that this year's allocation would take the total sum for this group of projects to 95.6%. And we're only at year 3. So that means just 4.2%, 4.4% of this 29.4 billion, we would just run for another 2 years. So that's the reason why I asked the question.
Yeah. Thank you, Mr. Chair. So a lot of these projects, we have started them maybe last year, and most of them would be completed this year. So as I said, it included the nursing schools. We have the distribution center that I spoke about earlier, the 5 distribution centers. They fall under this heading. We have been doing accommodation in different regions because as we send out people, we want them to have apartments where they can live. So we have been building a number of apartments. So all of that comes under this heading, and we anticipate that most of these projects would be completed by the end of this year.
Thank you. Thank you, Mrs. Chairman.
Thank you, Mr. Chair. Line item 240, 5600. It has provisions for ambulances and vehicles. Can the Honourable Minister state how many ambulances will be purchased under this line item and where will they be placed? Oh my gosh.
Honourable Minister.
Thank you, Mr. Chair. Under that specific line item, we have one ambulance. However, maybe just for you to know that the cabinet has taken a decision to set up emergency medical service, and so we have made provision in the budget for the setting up of GEMA, which would be the Guyana Emergency Medical Services. Now, that is going to be like a complete ambulance authority, and all ambulances in the public sector would come under that. It would have a structure, administrative structure and a technical structure. And our intention, and that's why we have the consultancy with Northwell, because the intention is to replicate an emergency service as they have like in North America, where response time would be defined, like within a certain amount of time you can get to the patient, which means we'll be pre-staging our ambulances across the coast, and then that's phase one, and then phase two, we go into the interior as well. It would be linked to one command center, and all the EMTs that we have, we'll be training them to make sure that they can respond appropriately. Now, the ambulances that we currently use, there are various types, some like minibuses. We are getting rid of all of that. We are standardizing the ambulances. And we want when an ambulance comes to pick you up, from the time they pick you up, they can start working with the patient. So we'll be training the EMTs to respond like that, which means the ambulance has got to have headroom for you to stand up and work on the patient. So you will see a whole change of the ambulance system, and henceforth going forward, all ambulances that we buy would have to follow this standard. Now, the other thing in the training that we'll be doing, we want to train the EMTs to respond to 3 major categories. One, trauma, of course. Any accident, they should be able to deal with that. Anybody getting a heart attack, from the time they get to the site, they should be able to start working with that patient, or somebody with a stroke. And then as we bring them in, the emergency system would also be realigned to make sure that we can deal with these types of patients.
Thank you, Mr. Chair. Can the Honourable Minister state what's the timeline for this, for it to be operationalized? And in the meantime, because we do have a 911 and 912, as that becomes operationalized, what happens in the meantime?
So
I understand that
right.
It takes time, but just
so
people have health issues daily.
I would say in about by mid-year, you would see a lot of this being put in place by mid-year.
And just a final question on this. I asked someone else, I think I asked Honorable Priel yesterday. Do patients, when they use the ambulance at Georgetown Public Hospital, are they expected to pay for that ambulance?
You shouldn't pay anybody. It's free.
Honourable Member,
and if anybody has been paying for the ambulance, you should let us know so we lock up somebody.
Thank you, thank you very much.
Honourable Member, Mr. Campbell.
Thank you, Mr. Chair. Honourable Minister, Project Code 440-2800. I'm assuming that the 3 new regional hospitals, Lethem, Cato, and Maruka, would be under that code. And specifically, my question is if we are still completing in August and October.
Minister?
Yeah, so far for Keto, Maruka, and Letem, we are on track. Right now, they have completed the foundation, so there's no reason why we shouldn't complete on time.
Thank
So these hospitals, as you know, they're a little bit smaller than the ones that we have out here. There are 50 inpatient beds, but they'll have similar facilities: accident and emergency, operating theaters, you know, good inpatient services. So like these ones now, we have moved away from the open ward, and you now have like 5 beds in a room with a toilet and a bath. So all the hospitals now would follow that pattern.
Thank you.
Honorable members, I now put the question that the sum stated for Program 474 capital expenditure stands part of the estimates. Those in favor say aye. Those against say no. Ayes have it. The sum stated now stands part of the estimates. Honorable member, we started at 2:47. The 2 hours which have been allocated for health was already consumed, and we are now into the last 7 minutes of the 35 minutes saved from last evening. Honorable members, please turn to pages 266 and 267. And I propose the question that the sum stated for Program 475, Health Sciences Education current expenditure, stands part of the estimates. Honorable member, Ms. Amanza Walton Desir. Mr. Mahipal speaks to you.
Thank you, Mr. Chair. This is a very quick question for the Honorable Minister. Line item 6302, training and scholarships. Does this line item cater for our medical students in Cuba?
Honorable Minister.
Thank you, Mr. Chair. No, this is all local.
This is all local.
Local training.
Thank you, Minister. Honorable members, I know.
Just one follow-up, sir. And it will be completely up to you and the Honorable Minister. Minister, could you just give us an update on the welfare of students we have studying medicine in Cuba right now, given what is unfolding?
Wrong head. Honorable members, I
Okay.
now put the
Thank
question.
you.
The sum stated for Program 475 Health Sciences Education stands, current expenditure stands part of the estimates. Those in favor say aye. Those against say no. Ayes have it. Sum stated now stands part of the estimates. Honorable members, let's turn to page 539, and I propose the question that the sum stated for Program 475 Health Sciences Education capital expenditure stands part of the estimates. Honorable members, I now put the question that the sum stated for Program 475 capital expenditures stands part of the estimates. Those in favor say aye. Those against say no. The ayes have it. The sum stated now stands part of the estimates. Page 268, and I propose the question that the sum stated for Program 476 current expenditure stands part of the estimates. I put the question that the sum stated for Program 476, sorry, the Honorable Member, Mr. Campbell.
Can't allow the Honorable, Mr. Chair, through you to the Honorable Minister. A quick one. I just noticed there's a significant increase in equipment maintenance, line item 6282.
Thank you, Mr. Chair. Yeah, indeed, we have a $361 million addition to that line item. So we're spending that $467 million It's going for radiology services in the regional hospitals, and also to make sure that the regional hospitals that we have reagents and so forth for them, the new labs that we open. We have another $17.3 million for blood transfusion services. This is going for refrigerators, freezers, and so forth. $5.5 million for the Food and Drug Analyst Department. This is to maintain things like spectrometers and fume hoods and so forth. And there's another $1.5 million for government pharmacy service, $4.1 million for quality assurance, the Department of Quality Assurance, the equipment they have.
Mr.
Thank
Chair,
you, Minister.
Some of this sounds like capital and not current. It doesn't sound like
maintenance.
It's maintenance?
To maintain the equipment that we have. So a lot of these things, the equipment, you got to calibrate them, you got to fix them, you got to, that kind of stuff.
Thank you, Minister. Honourable members, I now put a question that the sum stated for Program 476 current expenditure stands part of the estimates. Those in favor say aye. Those against say no. Ayes have it. The sum stated now stands part of the estimates. Honourable members, let us turn to Program 476 Capital, and I propose a question that the sum stated herein stands part of the estimates. Honourable members, I now put a question. The sum stated for Program 476 Capital stands part of the estimates. Those in favor say aye. Those against say no. Ayes have it. Sum stated now stands part of the estimates. 477, honourable members, and I propose a question that the sum stated for this program current expenditure stands part of the estimates. Honourable member, Ms. Sarabo Hali.
Mr. Chair, 6321, when you go to it, is Tommy Rehabilitation Center. There is an increase, which is noted. I was just wondering if the Honourable Minister can state if it's a case that Tommy Reed requested this increase, how do you determine whether or not the amount that you're giving them is enough based on what it is that they're doing or what it is that they want to do for the new year to determine the amount that they'll be given?
Minister.
Thank you very much, Mr. Chair. Thank you, Honourable Member, for that question. So what we have here is $122 million that is going to the Talmareed Rehab Center, and another $108 million that is going to the National Commission on Disability. So at Talmareed, one of the services that we offer, we give out hearing aid. But the earlier generation of hearing aid, you have to change the batteries, so, and sometimes to recalibrate them and so forth. So some monies are budgeted under this heading to be able to do that. We also have at Talmareed, that's the place where we're doing prosthetics. So a lot of the equipment there, we have been, you know, we want to give more people prosthesis. Before, people had to pay $400,000 to $500,000 for a leg. Now we're doing it free. So we are buying the material and we are making these things so that people can access them.
Thank you very
Similarly,
much.
and what you'll see, Honourable Member, in another month or so, we actually, because we have been doing these things using the traditional method of shaping it and whatever, but we have just, with the help of Northwell, we have acquired a 3D printer. And so in another month or so, we'll be putting that to use. And so we'll be able to print, basically 3D print the prosthesis for people. And they're more accurate, the sockets and everything are going to function better and fit better. So It's going to be like a more customized service with less problems for the patient.
Thank you, Mr. Chair. And final question, can the Honorable Minister state if there is a backlog of persons that are awaiting prosthesis and whether or not this amount will cover everybody that is currently awaiting?
Minister?
There is a backlog because up to about 2 years ago, people couldn't access this for free. So now we're trying to clear that backlog. Last year we did close to 100. 205 rather, because we had a special program with a team that came from India, and we were able to give more than 100 persons prosthesis through that process. This year we are bringing back that team, and plus we have increased the capacity of what we have.
Thank you very much, Minister. Glad to hear that the arm and leg is now free. It's free.
It is. So we have come a long way, Mr. Chair. One, if you got a hearing impairment, you're getting a free hearing aid from us. That would cost someone close to $90,000, and it's free. And we have budgeted in this budget to give maybe about 1,000 people hearing aids. I'm being told 2,000. And the same thing with prosthesis, it's now free. So whether it's an arm, a leg, you'll be able to get it for free. And outside of this heading, another thing that we've been doing for our patients on the dental side, we have 3D printing now at the dental school. So people who need bridges and crowns and all these things can now be done at the dental school. So we're advancing, using the technology to improve.
I don't know if the Honorable Chair will give me a chance to ask a question. Honorable members, we have gone 4 minutes over. Let me put all of the heads that are remaining. And these are Program 477, Current and Capital Expenditures, 478, Program 478, Current and Capital Expenditures, and I propose the question that the sums stated for all of these heads now stand part of the estimates. Those in favor say aye. Those against say no. Ayes have it. The sum stated now stand part of the estimates. Thank you very, very much, Honorable Minister, and your very, very competent and dedicated staff for taking us through your agency. Thank you so much.
Thank you very much, Mr. Chairman. And I want to thank all the members who asked questions. I think it allowed me an opportunity to explain the programs in more detail. And I hope that all the services that we are offering, that you encourage people to come and utilize these services. I want to thank the staff. As you can see, they did a lot of preparations, and you know, they had so much to share. But I want to thank them for all the hard work that they've put in, and we continue to work every day to serve the people of Guyana.
Thank you so much. Thank you. A couple of announcements before in committee, before we take the suspension. We have a standing order which speaks to the issue of people not in Parliament and those persons' names being raised in Parliament. We have an issue here with the Commissioner of Information. And the Commissioner of Information wrote, and I'll circulate this, he dealt with the issue of not being in Parliament to represent his office. So that's one. Second issue is the most important one I find. He says, There is no such mandate responsibility given to the Commissioner of Information, and someone was dealing with the issue of reports from the Commissioner of Information. I will circulate this now. The other issue is we have an outstanding matter, and we have the precedents dealing with the qualifications of Dr. Barker and the challenges made by Minister Griffith with respect to dropping out of a program. We're waiting on the information from Minister Griffith, and we have been given the information by Dr. Barker that he did complete his paid PhD. So we have one outstanding matter which has been raised, and hopefully before we end this evening that will be clarified. Honorable members, this is a good time to take the suspension.